Bangalore. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathy lovers, students, and doctors. We have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30, and from 8:30 to 9:30, the international session in English, and from 9:30 to 10:30, local language session in Malayalam. We are uploading the videos of the same on the very next day itself, so that those who miss the session can watch it again, and you can subscribe the same without paying any money. The purpose of this forum is to take homeopathy to every house around the world. And we have presentations from 85 countries, 65 countries, from eminent doctors as well as eminent personalities who love homeopathy, and everything is going in a good way now. And we have looking up to 2 months in Hindi session, and so also one for 1 month for in the English session, and even in Malayalam we have regular sessions. And today, let me come to introduce the guest of the day is none other than Dr. SHEETAL BIDRI. She has completed MD in homeopathy, that is in pediatrics. She is a founder and physician at Happy Healing and Holistic Homeopathy Clinic, Bangalore. Dr. SHEETAL BIDRI is a passionate homeopath and a holistic health practitioner, graduated her BHMS in 2015 and MD in homeopathy in pediatrics in 2018 from Government Homeopathic Medical College of Bangalore. Inspired to pursue homeopathy at greater height by learning under various eminent doctors in Bangalore, Pune, Mumbai, and Kolkata, she has been instrumental in editing some of the homeopathy books written by eminent authors in the field of homeopathy, has worked with eminent doctors Sunil Sarkar, and handles various forms of cancer through homeopathy and holistic practice. Currently, she practices in Bangalore at Happy Healing Holistic Homeopathy Clinic, serving the human in need locally and all over the globe via online consultation for over 10 plus years, and is a passionate over ever in learning homeopathy in depth and share experiences and break myths of homeopathy. She has successfully completed 2 seasons of conducting a consistently module for homeopathy students called 7 Days, 7 Remedies, where she encouraged homeopathic to adopt daily reading habit to improve knowledge and practice overall. She indulged in a good fitness routine of walking, running, and yoga, and inspire many more to do the same by setting an example. She focuses on treating patients in a holistic approach, keeping the mind, body, and soul in sync with the homeopathy, a good diet, and a healthy lifestyle. She is an active member at Instagram, YouTube, LinkedIn, Twitter, Facebook, and she is having prior appointments for consultation also. She has made some 2 to 3 presentations earlier in this forum, and today Dr. SHEETAL BIDRI will be talking about management of ENURESIS, that is bedwetting in children. So we proudly welcome our guest of the day, Dr. SHEETAL BIDRI. Doctor, you have joined in a different name, or please say yes. Okay. I can make you co-host. Okay, please wait. Yes, now you are co-host, so you can begin the session. We proudly welcome you to the session.
Thank you so much, Dr. Dhanesh. It's always a pleasure to connect with so many homeopaths all over the globe and on your YouTube channel to be featured again and again. And hope to add value to all the learning today. We have a quick 1 hour, but I'll try to I know we are talking a lot of homeopaths today, and my agenda today is to make management a little easier, not just with remedies, but also with other things that is possible. So yes, thank you so much for a lovely introduction. A little correction that I have done 3 seasons of 7 Days 7 Remedies, which I would again invite all of you all to join in the next season, where we just connect together and read one remedy for 7 continuous days to make a habit. And what you have done for the so many days, every day you're coming up and showing so many of us to learn. And this is something that is very inspiring, that you're showing up every day for, for homeopathy and for the greater good of learning of us homeopaths as well. So thank you so much, Dr. Danish, and the entire IFPH group. So let me
Thank
just
you.
share the
Yes,
screen.
yes. You can share now.
It says, have you given me the
Yes,
access? I'm
yes,
not able to.
yes, yes, you are co-host. You can share it now. Yes. Just click on the center stage there.
Yeah,
You can.
got it, got it, got it, got it.
Okay,
It didn't
it's
allow me the first time. The second time it has allowed me. Is my screen visible to everybody?
yes, yes. It's very clear. You can go ahead.
All right.
Everything
All right.
fine.
So today's agenda of learning something new. I would like to add value to practice. This topic is very close to my heart because I did my thesis in nocturnal enuresis, and I did it really passionately because I truly wanted to do something to learn the real efficacy of what homeopathy can do, or what a specific remedy can do, or a constitution remedy can do. So I was very passionate to find out, because and in MD we were giving topics, but my even not just the topic, but the experiment or the understanding of how it actually works when it comes to giving it to patients and trying to analyze not just result, only just the symptomatic relief, but also on a lot bigger picture, using research methodology and biostatistics to understand where we stand as homeopaths in treating a particular illness. And the topic I took was nocturnal enuresis, where today, the simple thing to do is to have a simple guide to help your patient achieve a good bladder control. Many of these learning, whatever we gonna find out, is useful also in adults. But today I'll be sharing more to do with children, and we'll see how we could optimize this in our practice. So, without much ado, today's content is going to be more to do with understanding what nocturnal enuresis is. It's okay, we can just brush up and understand what is enuresis and how we can diagnose one to be, or we can label them to have nocturnal enuresis. Second is to have to understand as a homeopath, how are we taking our cases of enuresis, right? How can we improvise it? And probably we'll learn with some case examples. And if time permits, I would like to do mostly the general management and the homeopathic management. Of course, we know there is a lot of scope in this and a lot of result oriented scope as well. But the general management, I'll tell you why I'm so passionate about sharing this, is because it works remarkably in every patient I have utilized. I have done this again and again during my master's and again in the clinic. And this doesn't this doesn't fail me. It always gives me good results. Now, understanding and diagnosis. First things first, we know that enuresis is something that is diagnosed only after 5 years of age, right? We know the bladder control takes place in uh, over a period of years, where the child first is doesn't have a control over their urination, and then slowly, gradually, they will understand that they have wet their pants. They will start showing to the parents that yes, they are wet the pants, and slowly, when the the parents are educating the child that this is the right place or this is how we do it. They start conditioning the child to use the pot or the the toilet to go for the urination. The achievement is happened over a period of 5 years. Some we see earlier as well, but scientifically we wait until 5 years. And more so, nocturnal enuresis refers to the occurrence of involuntary voiding, right? So the age is, I'm sorry, did I close it? Okay, I'm so sorry.
No, no,
Okay.
everything fine. Study
Yeah.
diagnosis.
So, because I can't see myself or anything in this, so that's so the 5 year age is, you take it with a pinch of salt. 4 is also okay, but nowadays children are achieving quite early. The understanding is much better. Now, what we can also know is the types of enuresis we have. That's a primary and secondary. Mostly, we see primary, that is, they have never achieved a bladder control over a period of time from birth. Secondary is when they at least achieve for a few months, and then something causes their enuresis to prop back in. So this is the secondary enuresis, what we call. Now, having said that, there's also another classification where we divide it between monosymptomatic and polysymptomatic, where monosymptomatic is uncomplicated, so we have only a voiding disorder, but no other symptoms. Most often it is the GI tract. That's why when the polysymptomatic we understand is bedwetting associated with symptoms suggestive of lower urinary tract dysfunction. So they can be other symptoms involved as well. Most often we see constipation as one of the reasons. So why does enuresis occur? So firstly, age, depending on age, it can occur to anybody. Of course, we will explore what are the other causes that create enuresis in a child who has already achieved or has never achieved. Most often we see the girls attain a bladder control much quicker than the boys, and even various studies that we see that 45% of 2 to 3 years old girls did so. They attain the bladder control much quicker than the boys of the same group, right? Um, and also depends on the learning. Now, children learn to control the bladder slowly by how the parent is instructing, how the parent is guiding through the training process, and mostly it occurs only when the child is developmentally ready, right? So if chronologically they have attained the age, also the actual age also matters, the developmental age matters. And now, what is conditioning? It depends on the conditioning of the child, how the parent or the grandparent, how are they making the child feel when, probably when they are wetting the diaper or wetting the bed at night, and how they have been trained over a period of time. That some children, or they understand that the once the buttocks is touching the commode, that's when they have to relieve their urination. So simple things like that. So over a period of time, the conditioning from the parents also becomes so very important. And now, um, just a second.
It's etiology. It's etiology.
Yeah, I'm just having a screen issue right now. Okay, no problem. So now, critical and sensitive period. Now, for example, if the child is going through um, a bully stage in school, or not happy, or divorced, or unsettling home environment, or just some reprimands in the house, these sensitive periods can also result in enuresis, right? We know the causative factor on this, the psyche of the child, how it can directly respond onto our body. And further, the child's developing ego and personality, how the child has developed as a person, the personality. If the child is sensitive, if the child is responding to a conditioning point of view from the parent in a different manner, the child has a temper tantrum, or the child is a very angry child, or the different constitutions have a different ego and personality that they develop over a period of time. And more so, it also comes with some amount of embarrassment, like, the if it has been labeled
Right.
by the
Other
mother or the grandparent, that also hurts the child's ego, and the embarrassment sets in, and then there is a snowball effect of not coming out of this wet night every night. Another reason can be the small bladder capacity. Most children could be having a definite capacity of very little liquid, and depends on how the diet has been, and then how the water intake has been also, and depends on that. Now, a very controversial would be the personality of mother. What I just said, how the mother is conditioning. Is the mother temperamental? Is the mother being very strict with the child? If the mother is most often I see in my clinic, not now, at least a few years back, we would see parents having to hit the child, or um, probably scold them or embarrass them in front of their friends. So depends on how the mother is also, responding to what's happening, and not really supporting the child overall. That could also be another reason that comes back to the how it can give a mental cause to the enuresis as well. Now, parents and grandparents, that is the most I see in clinic. The parents have a notion, and the grandparents have another notion. The grandparents say it's okay, the parents say it's not okay. The parents say it's okay, the grandparents have a different opinion. Now, in this, back and forth with this um, uh, uh, problem at home in itself can be leading to the next cause, that is the psychological stress. The stress, even the children do have psychological stress. First thing is that, the embarrassment that they go through. If the most often, if the parents are making fun of them in front of their peers and their cousins or anybody, that can again make them go into the stress, and they will repeat that cycle but not come out of that cycle again. And one of the most common one is lazy. Mostly in winters, we see that the laziness co- causes the patient to just, instead of going to the toilet, it's better to just do it on the bed. And nocturnal polyuria, ruling out things like diabetes insipidus or mellitus, and then how it really, what if there are any underlying causes, other systemic illnesses, metabolic illnesses, if that is causing, or just the child has profuse nocturnal polyuria, that could be a reason. And other infections, urinary infection, physical defects, infestations. Very common is worm infestations that can lead to irritation of the genitals and cause enuresis. Hormonal, if there is any lot of vasopressin given during any treatment. Sleep psychology, physiology, if the child is not attaining a complete deep sleep, and is because of that it results in enuresis, that could be a reason. Mixed social features, depending on how the child is being brought up, again comes to that. And ignorance of normal development. Some parents, they come for treatment for enuresis at the third year, second year. I totally do not give any medication for this, because it's okay for a child to have bedwetting. You just have to explain to them, explain how it goes on, and how they can achieve by 5 years, and give them the benefit of doubt that they still have time for the development to occur. So for us, it makes sense, to learn where we can give treatment and when we should stop, and how, if we can manage with general management and not medication, that could also be a good point, because parents would love that, okay, this doctor is not really giving me medication, but actually guiding me through understanding how I can give this a solution without actually just ending up medicating the child. So that could be a thing. Now, coming to the pathophysiology of it, is that the main components would be the inability to wake up during the sleep, the sleep psychology. What I'm saying, that there's so much, overpowering sleep that the child isn't aware, or also they're having dreams. Mostly often they have dreams of urinating itself. So that also could be one of the reasons. And nocturnal polyuria, like I said, there is defined this is defined as nocturnal urine production more than expected. So when the bladder capacity has more than expected amount of output for a particular age, then we can term it as nocturnal polyuria. And the reduced bladder capacity, an overactive bladder is the cause for small nocturnal bladder capacity. So because of it, the overactivity can be anything. It can be neurogenic, or it could be because of worm infestation, or many other reasons as well. So just a overview, so that we also just brush up what enuresis is and what can be the main components of it. Now, what the clinical manifestations usually, what do you think are the clinical manifestations? Let me see if people are listening, or we can interact.
Yes. Please continue.
All right, done. So it's as simple as having a wet bed, right? So I just was looking for an answer from the listeners, but no worries. Just having a wet bed. And now, only thing we want to understand is how we understand the history of the child. Having understood the etiology can give us a history of the child to be much deeper. Now, how much water intake the child is taking, if there is any excessive urination or thirst, to see if there's any kidney or diabetes, kidney problems or diabetes in this patient. Ask if the child is snoring. If there is any other respiratory illnesses, sleep is not being adequate. Sleep physiology is making the child too, making it wakeful in the night, or it is giving an irritable bladder at night. History taking becomes very important. And physical examination, where you check the abdomen, check the rectum after urination, see if the bladder is full, and then the child is being passing the urine. If there are any worm infestation, this can be checked by the parents itself, and also see if there are any other neurological complaints. Most oftenly, we can just do a easy fasting urine test only if there is other comorbid symptoms. Otherwise, if it is just plain organic enuresis, it's fine. We don't need to do any test. Most often, girls have a higher risk for urine infection, because they have a shorter urethra, and of course, and further tests are not needed if the child has no daytime symptoms or has a normal physical exam and a urine test. So no need to do more testing after that. Now, easy way to diagnose is the DSM-5, which is very simple to remember, but also ISD or ICD-10 also gives us a diagnostic criteria, but we can stick to DSM-5, which I usually stick. It's very simple. That is having repeated urination in beds or clothes, whether it's involuntary or intentional. Why intentional? Because the children, like I said about the laziness part, right? If the child is just lazy, and they don't want to go to the washroom, and they just urinate intentionally. So that also repeated urination, and now this has to happen at least twice every week, and this should go on for 3 months, or the cause or causes any distress or social problems. If the child is going through some distress or having a social problem, because of this, most often the social problem is they cannot go for sleepovers, they cannot stay with their cousins, so they have to be in their home environment. That becomes a social distress. And it should be more than 5 years, the developmental level, not caused by any medications like diuretics or medical issues like polyuria or diabetes, not explained by any other medical or psychiatric condition. So if they don't have any of these, then it is, an organic um, enuresis. So then we can treat them very, very, with conventional therapy or just, conditioning therapy with some homeopathy if it is really chronic and we get any PQRS. That is the best way to go about it. Now, same thing. Now, ICD-10 also says a similar one where age is more than 5 years of age. Bedwetting is more than twice per month if it is more than 7 years, not due to epilepsy, urinary tract infection, or other medical issues. No other major psychiatric disorder is present, and duration is at least for 3 months. So similar, just the little bit age difference of more than 7 years, but DSM-5 is most accurate and it's easy to diagnose as well. Now, moving forward, we've sort of understood what exactly enuresis is. Now, what is the improvised case taking? The second part of our agenda for today is improvised case taking. Now, for me as a homeopath, what is an improvised case taking is nothing but understanding the rubrics. Now, we know the etiology. We have taken, all the causes possible, the mental cause, what the social situation. We have taken a good complete history. Now, the only way to improvise our case taking for enuresis would be to understanding sub rubrics of, the main rubric being bladder urination involuntary at night, that is incontinence in bed, right? So morning towards when the urination is, when again this again tells us about the bladder control, right? So when the urination is towards morning, you can think of ammonium carb, cactus chloronum, and zincum. Morning, as soon as morning aggravation when they're sleeping, but in the morning they are urinating carbo-veg. At night, worse in autumn, that is in pulsatilla. At night in boys of light complexion, sepia. At night in fat children, red face, easily sweating, catch cold. Again, this shows us about the constitution, that is calcarea. At night, where the children are doing enuresis in the later part of the night, even if they have urinated during night and drank no water. So if you can see, a complete rubric analysis is given. I've taken it from various repertories, this amalgamated it together. So at night, where even though we have taken all general, this is where it becomes very important, because general advice is given that not to drink water, not go to urination before you go to bed. And still, if the child is being urinating, then we can think of chloralum. And at night in nervous children, gelseminum, very easy. Night in the children of phosphorus, build phosphorus. At night, pale, lean children with large abdomen who love sugar, highly seasoned food, abhor to be washed. That is sulfur, very, very common. At night in sclerosis, syphilitic children, Kali iode. At night, floods bed 5 or 6 times when there is many times is perim. At night with great fright, 2 years of age, that is phosphorus. Particularly in young girls, pulsatilla works really well. Around infancy, from infancy to 16, there is primary, right? So primary enuresis in girls, we can think of nux vomica. After a blow on the head, silesia. If there's a full moon aggravation as an obstinate case, also random. I have used it in my cases as well. It works really well. From any nervous irritation, we can think of magnesium phos. At night, while at rest, that is rustox. First part of the sleep, this becomes very important. First part of the sleep, or deep later on. Sepia is actually the most common. If there is a worm infestation, we can think of Cinna. And causticum, if they are way too sleepy and they're not able to get up from the bed, we can think about causticum. And phosphoric acid, when it's associated with some sort of weakness stability, we can think of it in the first part of sleep, because most children do enuresis in the first part of the sleep itself. And firstly, fairly flood the blood. So phosphoric acid, the sub-rubric of this basically. At night, during first sleep from which the child is roused with difficulty. So difficult to wake up the child, that is creosote. From worms, we can think of Cinna or Uridium nitricum. At night in children with worms and chorea, that is Silesia. Bed is wet almost as soon as the child goes to sleep. Always in the first sleep is Sepia. Sepia works wonderfully. I have used it for many of them. In my even dissertation cases, Sepia works wonderfully. In children with acidity of stomach, natrum phos. In children who grow up too rapidly, phosphorus. So constitutionally, if you can see, our rubrics give us a varied thing. I've not put the common one also. I've tried to put the uncommon one so that we learn something from it. I also, some of the rubrics were new to me as well. So um, Sepia is one of the key remedy which happens to be the common presentation in the children as well, because the first part of the sleep, and they have, as soon as they go to sleep, they start the do enuresis. And because it's difficult to do general management in such cases, because we give a plan for the child's parent to do, which I will talk in the end of the session, where how we can do general management, which is very, very simple and very effective in almost all cases. Now, when there is scanty urine, acrid, loaded, uric acids are deposits at catina, dribbling in boys. So mostly if you see in boys and if they don't get any cause, we can think of Rustox. Dribbling nocturnal and diurnal enuresis, both daytime and nighttime. We can think of Nux vomica. This is again repeated here with Kali iode. With thirst, aconite, alternating with dysuria is gelsemium. Feeling of weakness in bladder and genitals with fear of wetting the bed. Alumina, this, the older children will tell you about this. Mostly the 7-8-year-old will tell that, there is a feeling that I will wet the bed, I'll wet the bed, and they usually have sleepless nights as well. They try to fall asleep, but they'll wake up because of this, and then that whole feeling becomes very, very exaggerated for them. Now, involuntary micturition at night in bed, especially in little girls while coughing or passing fetus. You see little girls, you get pulsatilla very often. Wets the bed, restless, starts in sleep. That is belladonna. Also, they have that dreams of urinating. Wetting bed at night wakes them up urging but cannot retain urine. That is creosote. Wetting bed at night in children, commonly equisetum, caliphos, petroleum. And because of worms, it is cinna. And we can go on and on and on. So there are so many rubrics, which I have just selected a few of them. And these rubrics will help us to improvise our case taking. So if we take disease wise anything, the sub rubrics are the way how we improvise our case taking, right? So repertory not just suggest the remedy, but also if you know what you're looking for, then you can also ask, right? So you can only search for something that you know of. So probably brushing through some rubrics can make you think of these such and such remedy can be around, or at least you can just know that this rubric is there, and we can find it out later and give the remedy what is required for the child. Now, I have done a thesis on this, where this is one of the reasons why I wanted to do it someday. And when Dr. Dhanesh approached me, I said, okay, let me just take up this particular topic, because my topic, I did it very happily and passionately, because we took a two group study, where there is one group was given constitutional, another group was given equisetum, and we compared it. My original plan was to see if we can give homeopathy and only psychotherapy, that is conditioning, the general management part of it, but it wasn't approved. So I had to take a specific remedy and then, do my study. So little bit of, back and forth, but I was glad I was able to do this because I learned so much about equisetum as a remedy and its application as well. So I'll give you a little understanding of what I learned from this study, because the patients have been teaching me again and again in the practice. And this was a very good understanding of 60 cases where I could learn enuresis a little bit more deeper, understanding their follow-ups and how it works with real-time patients, right? So that is thing. So let me take you through one simple case, very simple. It's a primary enuresis case from from the childhood. The child has never achieved complete bladder control. The child has had enuresis since birth. She's At least they try to achieve it. Not more than 5 days she can sustain it. Something comes back again. Now the daytime, during the day also she has a lot of urination. 5 to 6 times is okay for the child. The 7-year-old female again passes urine at night if not woken up in mid sleep, and urination in the first part of the sleep. Of course, we will think about sepia firstly, but I did not let it affect my judgment. And she also had other complaints here, having vomiting of solid liquids after eating out, fried food, or overeating. So anything, little bit of a gastric disturbance was seen in this child. So she would vomit, even if she drinks water, she would vomit sometimes. And personal history goes like she loves junk food. She eats well, has a lot of craving for ice and ice creams and sweets, doesn't like greens like any other child, and the motions are great, but then sometimes also associated with constipation. Sleep is good, very difficult to wake her up from between the sleep, and she also has some fearful dreams. No dreams of urination, which I usually ask if there's any dreams of urination because the remedy changes. Um, and the child was chilly. So family history showed that the maternal aunt had bladder control issued. So she had bedwetting till 7 to 8 years old. The child had typhoid, chickenpox, arterial rashes in the past, and she's a very talkative child, mingles well. I still remember this child's face, and she also was very, eloquent. She would talk to me. She would, bring her toys. She would show me the toys. The mother says she loves to do pretend play in the form of, being the teacher. She wants to be the bossy one. She wants to, take the lead and everything. Even the games, she would want to lead the games as well. Loves to go out. She wants to move in open air, uh, loves to mingle with others, likes open air, loves to play on the swing, fears teachers in school, tries to be watchful of what others are doing so she doesn't fall into trouble, wants parents to be around, even during sleep, she wants the parents to be allowed. Because of the bedwetting, their parents are not in the same bed, but she really wants the parents to be around her as well. And a little bit of emotionally, she is, as any other child would need some little bit consolation. And here, this case was so, this is one of the first few cases where I just um, got it organically into my, and under my umbrella. And the analysis is quite simple. Like, firstly, of course, I thought, if you anybody can guess this remedy, right? This was a case taken directly from the case history. I've just put it without much of editing, so anybody can guess the remedy. You can put it on the chat box if you are um, actively listening. What remedy could be given to this child? So I gave the remedy of phosphorus. Now this phosphorus was given with monthly follow-ups. So phosphorus was given monthly single dose, and for 3 months we gave phosphorus, where she developed good amount of control, at least the frequency started reducing. Then there was a setback, and again we did it with a higher potency. uh, and this was one of the cases which really gave me a idea of how single dose can help. And if the right remedy is there, even a single dose is enough. Because a child over a period of, you know, 9 months with me. This I've written a 6 month thing, but over a period of 9 months, this child completely improved from having repeated wet nights to having no wet nights over a period of 9 months of treatment. So most of the last 3 months, I hardly gave any medication, but I needed them to come from my understanding, because if there was recurrency when there was no medicine given. So this particular case was there with me for 9 months, but medication was given only for 6 months or so. But then SL was continued for the child, and the child improved remarkably and did really well. Now, of course, I will tell you, apart from homeopathy, what did we do? I will tell you in the general management part, which all of my patients got to do. It went hand in hand. It was not just homeopathy, but also the general management that I still tell my patients to follow. I have a 5 pointer that I usually follow. And I know I specifically tell myself 5 pointer because I shouldn't miss any one of it. Um, so that is the case. And since these are the cases from my thesis, I'll just give you an understanding of how I would be with that particular child. And I understand if there's any family history, because this was also a point of me analyzing in my thesis if there's a correlation, which there was. And type of enuresis, and what are the totality of symptoms, and what remedy I gave. So a 30 constitutional remedy. I'm just giving you a gist of who was there. Some cases just improved, where there were a few wet nights over a period of the last follow-up, but some of them remarkably did not have any wet nights after a good chunk of treatment done. Now, having said that, there were also for secondary enuresis as well, where again, even if it is just 3 months, if they were having bedwetting 10 per month, they ended up having 0 per month. Or if there were 4 months with me, secondary enuresis within 4 months, from 30 wet nights to 10 wet nights. So there is still a good understanding of how constitutional medicine helps, and how homeopathy helps as well. So this I have a whole history of 60 cases, but I'm just giving you a glimpse of what I did. This is directly again from the case, because I somehow wanted to write this to show how exactly I did it. Similarly, I'm sorry I haven't blurred this. It got mistaken for some reason. I had added something. So if you can see, I ask every patient the sleep time, the last meal they take, the bedwetting, how many episodes and what part of the sleep, that is 2:30 a.m. and 8 a.m. again in the morning, if there's any offensivity, if the child is a deep sleeper. So this is another case basically where I understand, and to get my details, a good history is very important as well, right? So the child is a deep sleeper, difficult to be aroused, aggravation during winter and fanning, history of daytime incontinence 2 years back, habituated to pass urine at night, no fears, no difficulty in school. And there was, again, see, if you can see, there was, paternal aunt had a neurotic problem till 22 years. So strong family history is correlated in most of the enuresis cases, where somebody in the family had this issue. Mother was also enuretic till 7 years of age, and appetite good, thirstless, desires sugar a lot, cold water desires from the fridge. So, here I had to give, because it is just out of habit, and as a 15-year-old boy, I wanted to give equisetum. So I would do equisetum, BD for 3 days. and then repeat that monthly as well, so that we understand if this really helps. So now the advice part I will tell in detail in the last section of today. This part is so important, which I would tell everybody. And if you can see, I've been using 5 pointers since 2017, and it still works wonderfully for me. So even with equizitim, even if it is not the constitutional treatment, I was able to achieve a lot of improvement in enuresis over a period of 5 months, 6 months, 7 months, 8 months. So if you see in constitutional, I was able to achieve almost zero sometimes. But in equizitum, there would be some improvement, but not a long-lasting one, is what I understood. But the interesting part was equizitum was given as a specific, because equizitum, if you see in our repertory also, it says that out of habit, if there is enuresis, then we can give equizitum, and then it works really well. But I saw that only even if I gave only equizitum, the child really improved mentally as well. That whole outlook towards enuresis, the whole outlook, if there was any distress in the child, if the child was naughty, or if there was some sort of setback or embarrassment, the child actually improved mentally as well. So I actually got a lot of clinical symptoms of equizitum in this 30 cases. But of course, it's a small pool again. 30 cases also, it's a, probably if we do a bigger study, we can, add it in the repertory. But yeah, using enuresis has helped me learn a little bit about enuresis equizitum as well. So if you see, be it whatever, even if they're dreams, be it even if it's the second part of the sleep, even if it is not out of habit, if I give, it has improved, but not completely. But this particular child who I showed the case of, it was just purely out of habit. That one improved. So the indication matters. If it is given on the basis of what it is for, then it is short. So understanding the sub rubrics of our repertory can help us to give short prescriptions for sure. So I have another 10 minutes to go. So I will just quickly rush through a little bit of, so this is just an overview of my study, where with constitutional, only one didn't improve. And then that I blame to my setback, I think, because homeopathy doesn't fail. It's us homeopaths who fail. So that is, I feel it's my setback. But with equizitum, if you can see, improved were there a lot, recovered only two. Recovered is when they had no dry nights at all for 3 months. So that was only two of them. But overall, net, homeopathy wins. So homeopathy works for sure. That was one good thing, but also understanding what really works. So yes, constitution definitely works much better for a long-term outcome, definitely. Now, we've done a quick overview, but a little bit about, I spoke a little bit about the specific remedies. I will not go into it because we have, I mean, I had to like do it in 1 hour, so we have 10 minutes. And a little bit about equizitum
Yes,
is something I would like to
doctor, we can have a second part of the same because it's a very
no, I tried to concise the whole thing into, like, because it was a very wonderful 60 cases study, which I thoroughly uh, I think I did good, okay justice to it. Probably I could have, maybe now if I do the study would be much better. Now we all know that constitution, like even with the study, I can say that constitution really works wonders. But also PQRS and symptomatic have short results. Like if you go to the sub rubric and understand, one of the easiest way to learn is to just read the repertory, and I love doing that. Read weird repertories, even if it is not there in Kent. Please go to another repertory and read them. Very this thing. So here in my study, I use a specific as equizitum. There are other remedies also for enuresis as a specific. But out of habit, it is usually because with equisetum. So a little bit about equisetum before we close for today. So this is from I think this is from Boric. Yes, it's Boric. And equisetum, if you see, he writes, it's got a principal action on bladder, and it's the remedy for enuresis and dysuria. Even if they have out of habit or there's pain, we can think of equisetum. E for enuresis, E for equisetum. So there's always a understanding. We can never forget equisetum as a remedy for habitual bedwetting. So severe dull pain, feeling and fullness in the bladder, not relieved by urinating. This is for the dysuria. Frequent urging at the severe pain at the close of urination. There's a pain, not burning. Urine flows only drop by drop, sharp, burning, cutting pain in the urethra while urinating. So this you can use it for dysuria as well. Incontinence in children with dreams or nightmares while passing urine. Um, Incontinence in old women also is useful with involuntary stools as well. Retention and dysuria during pregnancy and after delivery. Much mucus in urine and albumin area, involuntary urination. Now, this equisetum, actually, I have used it even in adults. Sometimes when they have, um, you know, a frightful dream and then they have passed urine. So there were a few instances which happened. Also, I had an adult case recently who had dreams of urinating as well. So, any guesses for the remedy? Urination, dreams, involuntary urination because of they think that they are in the washroom. Any guesses for this? Let me just probably okay. Let me just go back to the probably the Dr. Dhanesh, they can tell you
The medicines creosotum
the
verbal
urinating. So having said that, where is my
lacunin
screen?
version cursia.
Yeah. And so, yeah, this is a little bit about equisetum. The main part of today, which I don't want to miss, is the general management. I have, I think, 7 minutes. I will finish it with 2 minutes to spare. So, for me, these 5 things really, really worked. And this is something that I think even if you use it for any cases, it really works, especially if they are closer to puberty. It works awesomely. First thing is the star chart. Second, what is a star chart? I used to just take a pen and paper, write the dates. You can give them a calendar also, or just write one, two, the dates of the year. And on the dry nights, you reward them with a star. So I used to give a sticker or just a pen star. That also is okay. So the more starry nights, okay, in the calendar, there is a reward for the child. So this reward system becomes a conditioning therapy for the child to achieve bladder control over a period of time. So this star chart works amazing as a reward system for dry night. So whenever it's a dry night, you give the child a star. Now, second thing is fluid intake during the daytime and nighttime. So
Doctor,
flooding body. Yes, yes, Dr. Dhane.
screen is not visible now. It's
Oh, there's nothing what I'm sharing actually.
click to the exit full screen. Okay.
Okay, what is this? Where is this? Oh, so sorry. I have shared the wrong window. Yeah, nothing. There's just nothing. I'm mostly talking than the screen. So fluid intake during the daytime is very important. Flood the child with a lot of water during the day. But after 6 p.m. is something that we will not give them water, especially in terms of after the dinner, one glass of water, and that's about it. They can do the urination before they sleep, and then they can go back to sleep. Last meal timing has to be 2 hours before the sleep time. So if they're sleeping at 10 o'clock, they have to eat their meal at 8 o'clock. And then they can have the last glass of water at around 8:30, and that's about it. So that helps them to have the bladder control. even if they are not waking up in the first part of the sleep, it's important. The fourth point is that forcefully you wake the child. Even if the child is not completely awake, you take the child to the bathroom, so that it's just a conditioning process. You take the child to the bathroom and make them urinate there. So even in the subconscious level, they start understanding that the urination process happens inside the bathroom. So that is the fourth point, and the main point is the diet advice. The diet advice is a little elaborate, but if I have to give you an overview, no water at night time, completely no of sugar or any kind of candies, packaged food, everything that has a lot of added sugar or added salt. Nighttime, you do not give anything like milk, yogurt, because calcium makes there is because of calcium there is a high tendency to have more urine, and the child can have bedwetting. So we can give all these things in the daytime. And yeah, I think I covered most of it. Give high omega-3 fatty acids as well. So yeah, the diet part is important. I have 3 minutes. Just overall recommended food is folate, fiber, vitamin B12, omega-3 fatty acids.
Yes,
Um,
yes, doctor, we can conclude for the time being because we have to a formality of
yes,
saying vote of thanks. Another big session comes.
no problem. Okay, I will just close it. This is all. We can if there are anything we can discuss, or oh, I'm so sorry, I have not edited this slide. I'm so sorry, that's not my address. So I will. My details are there on the message given in the WhatsApp group, and we can discuss further. But yeah, this is the overview of how I manage, or how it's easy to manage enuresis in the clinic. Thank you
Thank
so much for this opportunity.
Thank you, Dr. SHEETAL BIDRI, for a beautiful presentation, and you really rocked the floor with your research work, also your PG in pediatrics and all that. You really deserve that. You can go ahead for a PhD also now. And definitely, there are a lot of questions coming in, but unfortunately, due to lack of time, we have to cut short the discussion. And
Yes,
hope you will come out as early as possible for another session, so that
sure, sure,
we can give at least 15 minutes for discussion
sure,
and
sure.
in the with the pediatric subject itself, so that there are a lot of questions coming from doctors. Anyway, congratulations and thank you very much. And I am inviting Dr. Manoj to say a vote of thanks to the session. Dr. Shaji, could you have you? Okay, Dr. Rambar, let us go to Dr. Rambar to say a vote of thanks to the session. Okay, sir.
Thank you, Dr. Dhaneji, and congratulations, Dr. Sheetal Madam. Very nice presentation, excellent session, dynamic. Dynamic is the homeopathic medicine. Ecudatum hilum and cascum is a very good remedy in resist, case of enresis. And natrum for, and many symptom, burn flag symptoms, Sina is a good remedy in resist case. So very, very thanks, Dr. Sheetal Madam, behalf of IFPH, whole team, very, very thanks. Thank you
Thank,
Thank you,
again,
thank you,
presentation.
thank you, sir. Thank you so
thank
much for
you.
this opportunity.
Thank you, Dr. Ramparesa, sir, and Dr. SHEETAL BIDRI, and those who attend the session this evening. And tomorrow we will have a session from Dr. Paul Joseph, and Dr. will be discussing about power of pain. And that's another big day is coming, waiting for you. Hope all of you will join us by using the same link that we shared for today. Thank you all. Good night.
Good night. Good night. Thanks, guys.
Now it's up to Dr. Manoj to moderate the Malayalam session.